Hey guys, welcome to another episode of DarshanTalks. I'm really excited to have with us the CEO of Hightower Clinical. It's an integrated site network. He's the host of Note to File podcast. It's a podcast for clinical research sites. Today's interview is brought to you by the Kulkarni Law Firm, and the interview is about clinical research. What are the big issues that sites are facing? So if you care about clinical trial sites, you care about what's happening with them, why are they performing the way they're performing? Do you, as a sponsor, need better performing sites, and why are you choosing the wrong ones, or why are you choosing sites and they are not performing the way you wanted? If you are a clinical trial site and you are hoping someone can champion your cause and talk a little bit about what are the big issues that you're facing that not enough people are talking about, this is the conversation you want to listen in on. Our guest today, like I mentioned, is the CEO of Hightower Clinical. You can actually reach him on LinkedIn at brad@hightowerclinical.com. He also has his LinkedIn profile at Bradley Hightower. You can also go to his two websites, which is the Note to File podcast and clinicaltrialconfidential.com. And I'm going to ask him to speak a little bit about what each one is. But I really appreciate you all being here. This is the DarshanTalks live stream. I'm your host, Darshan Kulkarni. Please feel free to reach out, ask our guests questions. Please leave a comment. Please subscribe by hitting the bell icon. Please share. Helps with the YouTube algorithm. You can always reach out to me on Twitter at DarshanTalks, or go to my website, DarshanTalks.com. And let's sort of get started. Brad, great having you on. Thank you so much for coming on.
Yeah, I appreciate it, man.
Before we get started, I want to talk to you about the two websites you have. So the first one is Note to File podcast. Can you talk a little bit about what that is?
Yeah, and I think even more broadly, both websites are my humble attempt to address an issue that I've seen in my career at the research site level. I really feel like there's been not enough good resources or conversation that sort of centers around sites. So initially I set out here with Note to File podcast to really sort of help both capture site voices and provide some sort of resources that are useful for sites. So I've kind of opened it up a little bit. I've only about 50 episodes in, but kind of opening it up to people outside of just the research site level. But really, again, as an attempt to sort of provide some value to the site community. Again, I feel like it's very hard to find good information at the site level, especially if you're talking about, vendors and all the different solutions that are out there. So that was really my hope there, and to really just have more casual conversations with people about clinical trials and the issues we face at the site level.
I mean, one of the most famous podcasters I know, and I've known him for a long time, as it sounds like you have as well, is Dan Safara, and he's been championing sites for a while as well. Dan has expanded into a whole bunch of different locations, and he does sponsor level stuff as well. What is the goal for someone like Brad Hightower? How does he conquer the world?
I mean, it's a great question, and I'm not sure that I know yet, if I'm being perfectly honest. My first sort of hope is to at least start to create some consensus amongst the site community so that sites can better leverage their value. I mean, none of this stuff works without sites. And oftentimes, when I stand back and look at how the industry works, I'm just shocked that it hasn't imploded on itself yet. And I'm surprised that, some of these trials are successful. So again, it was really more, I guess step one is sort of like, let's come to a consensus and identify the issues that are the biggest pain points for us, and then determine how together, we can help address these issues.
I mean, you already started doing that, possibly even before the podcast, by creating an integrated site network. You were trying to bring that consensus, to build that consensus. Talk to me a little bit about that journey, because I feel like integrated site networks are an offshoot of the original SMOs. And SMOs got a bad name because they really were a good idea as a solution of sort of bringing site voices together. But what you landed up with was bloat. And
Right.
There are now, and there are different terms for it, integrated site network being one of them, which is we want to avoid the terrible damage that SMOs did, but we have a better process. We have a better system out there. And I work with sites all the time who do have a better system out there. talk to me a little bit about how you do it differently, how you do it better.
Well, and I think first of all, I worked in academia. I also worked for a large hospital system, and it occurred to me really early on that these were just bastions of inefficiency. They worked terribly. The incentives weren't well aligned across the institution.
I'm sorry, Brad, when you say these, do you mean sites? Do you mean academia, or do you mean something different?
I think primarily large institutional sites, and again, not to clump them all together too much, but I see this as a general trend, and I talk to a lot of CRAs and sponsor level people, and I think it's not out of hand to sort of make that generalization. So I'm generally referring to more large institutional sites, and so it occurred to me though throughout this time I was talking to a lot of physicians in the community who were interested in participating in trials but didn't have the infrastructure or the money. We know that this is not always a financially lucrative option, especially if you're a small private practice. So what I wanted to do was provide the infrastructure for free, end to end, and we split study income as it comes in. So my hope was to remove that burden as much as possible from the physician and get us into these communities that don't have access to clinical research. So, that was really the whole idea behind it. I think it's very challenging especially to scale, because I do think in order to succeed, you have to really personalize that offering across the different clinics or practices, or even physician to physician. And that, I think, to sort of go back to your idea of SMOs and bloat, I think it's incumbent you have to be agile. You can't have too much bloat, because again, each physician is coming from a different motivation. They also oftentimes want to have different levels of involvement, depending on what their interest may be. And so I think in the interest of actually increasing access to trials, we have to be sensitive to that. And that's a big part of our sort of mission, I guess, is making it. I mean, we have to make this. We have to make these guys want to participate in trials, and I think it's incumbent upon us to do that.
Which is really interesting, right? Because the entire way an SMO could avoid being bloatware, for lack of a better term, was by standardization. That was the entire point. That was the entire goal. And the reason they failed, in my opinion, and again, I've been in the industry for 20 years. But the reason I think they failed is because of exactly what you're talking about, which is every physician wanted a unique customization for them, which makes sense. I mean, as a solo practitioner, I totally get if it doesn't work for me, I don't want to be part of it.
Right.
But on the other hand, that's not standardization. Now it's unique customization for each one. And if you were theoretically in the SM, if you were a sponsor and you go, should I work with an SMO? Yeah, that sounds like a great idea. I get access to 20 sites at the same time with one single contract or one single signing of the pen. What you really land up with is 20 contracts that have to be negotiated by the same single location. Say 20 budgets, 20 everythings. So talk to me a little bit about how this new generation of SMOs, or this new generation of whatever you want to call them, sites coming together, are avoiding those mistakes from the past.
Yeah, I mean, and it's a fair question. I mean, I think to your point, there has to be a certain level of standardization, and even to your bigger point than that, it could be that sites or SMOs or whatever you want to call them now, the lines are really starting to blur. At this point, I do think to some degree their reluctance to adapt is causes issues too, because now you go and if you have 50 sites in your trials and they all run entirely differently from each other, they all have completely different rules as to how they operate, and that is a problem. You are right. So I think there has to be the balance, right? So I think you can standardize a lot of the centralized things that you do, and then at the site level, how you interact and operate with your physician, more of the soft skills or soft part can be more customized and different. I mean, some physicians bring us their patients. For some of them, we have to dig and bring them the patients. And I think those are the sort of subtleties and nuance that now, do they truly change the dynamic with the sponsor? Maybe not, but those are the things, again, I think you really have to take a more personalized and customized approach. But that being said, I mean, you can run your regulatory in a standardized way. You can do your budgets in a standardized way. So I think it's just that determining and being smart enough to tell the difference between what needs to be standardized and what needs to be personalized.
Which is such an interesting discussion. So what I think you're saying is that for the sponsor, what the new generation of sites coming together are doing is they're trying to make that that diversity in goals. They're trying to make that opaque to the sponsor in a good way, in that the sponsor doesn't have to deal with the 50 different sites. The sponsor deals with one window, and all those issues are being resolved in the background. But how does that work at the integrated site network level? Because as you pointed out, there are 100 different variations. Each one's doing their own thing. Does that, in some cases, you're finding the patients, in other cases, the physician's finding the patients. So all of those things have to happen. You mentioned, for example, budgets. On one hand, I totally 100% get the yes, the budget can be sort of standardized. But on the other hand, I don't see how it could be if you're in exactly the scenario you're talking about, which is if you're new to the system or you don't use their system as often as they do, it just lands up costing you more money to go through their system to find the patients, which means that's a cost you're taking on. So the budget necessarily has to be higher just to address these types of differences. And then what no one's talking about, and it's sort of the elephant in the room, is the fact that I think if I remember correctly, only 3% of physicians participate in clinical trials. And at the end of, and again, I could get the numbers wrong, but something like at the end of every 3 years, there's 100% turnover in physicians participating, something ridiculously high, like 98% of physicians, this turnover, which means that you as the integrated site network have to maintain that entire churn. So how do you manage this flux?
Yeah, very precariously. No, and again, I do. It's a challenge that we still face, and again, I think a lot of it comes down to how well you support that physician. I mean, frankly, a physician who's not well supported is not going to participate again. It's got to be both, at least financially neutral, if not lucrative, which it can be, and I think it also has to not be a pain in the ass. And frankly, it is, right? But who's going to take that burden? And that's where, in my mind, that's really incumbent upon us as a research network to make it as easy as possible for them. So yeah, and then to go back to the budget thing, it's a fair point you make, and there is some nuance there that I think if you do want to standardize, you'd love to standardize recruitment, right? So that you can account for it, across all. But the truth of the matter is, it just doesn't work that way, and you can't plug everyone into the same hole. It's just not realistic. Now, I think you can still account for that in budgets in a more broad, generalized way, so that you don't have to have, well, this guy over here, we use a EMR query tool and it costs us money, so we need to tack on. But this guy over here, he just hands us our patients and it costs us nothing. I think you can still, sort of standardize that or manage it at a level to which it doesn't require, 20 different contracts. And obviously that's the hope, right? I mean, that's the leverage a network brings, that you don't have to do those things. So yeah, it's a complicated question to your point. I mean, it's deciding what you can standardize and what you can't. And that's not always clear. And that takes time. And I think some real ability to reflect, to sort of suss that out as you go along.
I work with site networks all the time. I represent them. One of the things that has become an issue that's always fought over, and is becoming more and more important as time goes on, is who owns the data. So is it the physician, who appropriately needs to own the data to help the patients? Is it the site network, who appropriately needs to own the data because they're signing the contract, which may often land up being how you transfer the data over? Is it the CRO, who's then representing on behalf of the sponsor. Like, there are so many stakeholders, all of whom say we need to own the data. How do you address that?
It's a good question, and I don't know that we've really fairly addressed it, if I'm being honest. I mean, we, obviously consider ourselves, owning the data that we're generating there at the site level. Now, what we can do with it is another question, right? I mean, it's there, and we have access to it. We can't go out publishing it or, violating the contract in any other way. So I think that's a great question, and probably something that we've not really addressed with any clarity at this point. And it hasn't been an issue, at least to this point. So I'm going to knock on wood, and hopefully I don't have to call you someday and say, please help us, because now there's a big problem. So, I mean, that's actually a fair question. I mean, are you seeing this being done in a standardized way across these site networks? Is there sort of a prevailing thought there?
So what I'm actually seeing is site networks being bought and sold.
Sure.
And when that's happening, the big reason they're being bought and sold is because they have data. And the problem then becomes, do you actually have the data? What does your contract actually say? And that's when you start going, I don't know.
Yeah.
Like, one version of the contract may say that, one agreement with one site may say that, but is that across the board? Do you have a standardized contract? So that's when you start getting into the iffiness of this. And the people who want this, quite honestly, are the tech companies, because the tech companies are going, I would love to own patient data because I want to bring a health solution out, and the only way I can bring a health solution out is by testing it on actual patient data, and I have no way of getting it. So this becomes one way to access it.
That's an interesting point, and something that I've maybe distinguishes us is that I don't have any interest in doing anything other than running good research across with the research sites. I know there are some of these companies and even integrated site networks that they're probably are more interested in data and technology versus actually operationalizing and executing clinical trials. So that's a really fair point, and I think it's probably more prevalent than people will admit. But yeah, for me, it's always been about executing trials. So I guess in that regard, it hasn't been quite as much of an issue because I have no intent on selling that data or selling anything. I love this. This is what I want to keep doing and building.
Yeah, but I mean, theoretically, if someone came to you with an obscenely high number, you'd consider it. But the question then becomes, what was the high number for?
Right.
And
yeah. Fair point.
That's where the issue lands up coming in. It's an interesting statement you made earlier, though. You spoke about this idea of you own the data, but what can you do with it? And then the argument I would make to you is, do you really own the data? If you don't, when I use the term ownership, it means you can do everything with it.
Gotcha.
However, what I think you're using the term for is, can you access the data and what rights do you have to the data? Because that means that if you say, I cannot do anything I want with it, then you may have access to the data. You may have sub-licenses to the data, but you may not actually own the data. That's a really simplistic way of looking at it, because theoretically you could own it and then have out-licensed yourself, but I'm keeping it simplistic.
Sure.
But I guess my question for you is, do you, the versions of the contracts you use, do you find yourself dealing with this question of physician X, we need to see from a pure feasibility standpoint, and let's explore that a little bit, right? One of the big issues you deal with, and I'm sort of paraphrasing something you said earlier, but one of the issues is, am I the right site for this potential clinical trial? A site feasibility, if you will, usually done by the sponsor, but the truth is, the site has to give a lot of that data to make sure that they meet those criteria. And there are one of two ways of doing it. One way is the site actually does the analysis, or the integrated site network does the analysis because they have the data and then gives it. But that only works if the integrated site network actually, the ISN, I'm going to start calling it ISN just so people understand what I'm saying, but only works if the ISN actually has the data available to it. So how do you play with that flux, that tension there?
Yeah, and that's again a great question, and I think we see it vary depending on who we're dealing with. So we have small private practices who are, frankly, maybe not as worried about data access, and then we're like today, I'm sitting in a large hospital system we work with. It can be like pulling teeth to get that data sometimes, and it can take weeks or months or whatever the case may be. So I think this is digressing a little bit, but what I'm finding interesting is this sort of rise in these different solutions that will tie these EMRs together on the back end. You can query through AI and natural language processing. You can go through unstructured data. Really interesting concept. Again, almost sometimes impossible to get that level of access. So we try to make that clear when we're dealing with these groups up front, through NRBAA and, executing these different, parts of contracts with them, that like, look, we're going to need data access. Now, I don't need to own it. I just need you to access to it so that we can do what we do. So no, that's a good question. And maybe something, for us being still sort of, I could still kind of consider us new kids on the block. We're fairly small. Something we need to consider more in terms of the actual, ownership as things go forward. So no, it's interesting.
It's interesting. You spoke a little bit a few seconds ago about this idea of data interchange happening at the back. I mean, we all know how amazing Epic and Cerner is. So obviously there's no issue with that. I've worked as a pharmacist for 20 years, and I can tell you, Epic and Cerner never gave me any problems. It was just the best thing ever. So we'll ignore that for a second. But you one of the things that's come out in the last year or so, I want to say, is this idea that data interchange is basically been made legally required. So a lot of these companies are trying to figure out how to make that data interplay happen. There also were, as I'm sure you know, a bunch of tech companies came in and they tried to say, oh, let us hold your data for you. We'll be the data repository for you. We have no ill intentions. We just want to help patients. Let's say people didn't go for that. They didn't buy that. So I guess my question for you is, do you find yourself in a scenario where you think that's going to help you, this tech company, or do you think that between the sites having this inherent distrust in, distrust is a strong word, but tension is probably a better word, the inherent tension with sponsor goals, but now these new entrants, whether they're tech companies, data companies, whatever you want to call them, is it the enemy of my enemy is my friend, or is it something completely different?
No, I think, at least for me, there's some cautious optimism that I think these things will contribute. I mean, but look, at the end of the day, what we do at the site level is still very sort of time intensive, right? Nothing is going to just pull the perfect patients out for you. Yeah. It's still going to require a great deal of oversight. But frankly, if you can start further down the funnel, that's going to increase, everybody's efficiency, considerably. Now, I'm not convinced yet that, I've been in these EMR systems, all of them. I've seen how doctors use them, and you get into sort of a garbage in, garbage out situation. So, if, these clinics are not utilizing their health records in a way that's, usable at the end of the day, then it really doesn't do any good. So that's where I still hold some skepticism that it's going to be as useful as it's being sold. But I do think, again, if instead of me having to look at every chart every week, if I can start with a list of 100 that's pre-qualified as much as they can be, then that is potentially going to be a big boon for sites.
I don't know why this became a full-on data conversation, so I apologize for that. That's not the focus when I started out this conversation. But I'm going to ask one more question that's kind of interesting. And I think you're uniquely placed because you advocate for sites, but also as a result of advocating for sites, you advocate for patients. And my question for you is, we always talk about sites owning it, ISNs owning it, CROs owning it. No one talks about the obvious place, which is, should patients own their own data? Why is that? Do you think that should be where we start and everyone just sublicenses it from there? Or do you think that that's just a pipe dream?
No, I think it's a great idea. Now, again, a lot of this, I mean, to be perfectly frank, a lot of this is completely over my head in terms of outside my scope of knowledge, even. But I mean, it makes a lot of sense to me intuitively that a patient should be able to own their own data. Look, I am still having to send 5 faxes to the rural clinic to get patient data that's incomplete or, not useful in any way. And I feel like this is a huge problem. But if a patient were able to, own and control how their data is used, I mean, again, I don't know why tokenization couldn't be something that exists down the road. Again, out of my wheelhouse of knowledge, but it seems intuitive to me that would be the future. So I think that's a great idea. I think it's very realistic. I think not if data companies can keep it from happening, because they're able to monetize it. So, they are probably going to fight that if they can.
It's fascinating because there are 2 conversations happening at the national level. One is patient data privacy. So the whole question is, and it's funny, the Dobbs decision from the Supreme Court precipitated a lot of these conversations about who should own the data, or should you even have access to the data around a woman going to an abortion clinic. And I'm not making a political statement at all. I'm just talking purely from a privacy data perspective. A lot of tech companies are saying, we're going to delete that data. We won't have that data. Already turns out there are middlemen who have that data and are selling it already, but that exists. So it's going to be a interesting conversation. The other piece of data, other piece of information that I think is interesting and that plays in is, what is data? So we think of data as digital information, but what no one's talking about is things like DNA data. And what goes into that is, you had 23andMe, and you had I forget the other one, Ancestry.com. They were collecting your data, and then they sold it for $500 million to a pharma company, and no one knew that was happening until too late. And now there are all these rules out there that they've self-disclosed. They're like, we think there should be rules. Well, yeah, you already made your money.
Yeah, now you think there should be rules.
Exactly, but I feel like that, and they will say that it was in the terms and conditions the whole time, and I believe that. But it's interesting. So the point I'm making is, from a patient data ownership perspective, the big question that you land up with soon enough is, what is data? Is it just your digital footprint, or is it also your DNA footprint? And turns out your digital footprint is significantly more valuable than your DNA footprint, which I thought would be more valuable, but turns out no one actually cares.
That is kind of counterintuitive. Well, hey, at least we've managed to find some serial killers along the way, right? With
I missed that part, really.
I know they've used those registries to track people down through DNA connections. So
I find that to be kind of funny. The idea of like your stepdaughter, well, your daughter goes for a DNA test and you find out being caught as the serial killer.
Right.
Awesome. Before we go, we're well past time, but and I apologize. We went down a totally different route than we planned when we started this conversation. So unfortunately, it means that you'll have to come back if you're open to it.
My pleasure.
And it'll be a lot of fun. But before we go, how can people reach you?
I'm on LinkedIn, very active there. Not much else social media wise. So that's really probably the best bet. You can always hit me up on email, brad@hightowerclinical.com. I live and breathe clinical trials at this point, so I entertain just about any conversation that comes my way. I love any opportunity I can to connect and, rant almost, if you will. So those are probably the best ways to reach me.
That's awesome. And any parting words?
No, it's just I appreciate you having me on. We did go down a little different path. Data is a little outside my realm, so I'm hoping we can go again and dig down into those site level issues. But again, I really appreciate you having me on, man.
Thank you, and we will, because I want to have that discussion. and there's so much more to talk about. Just to be clear, what we hope to talk about and we hope to bring Brad back on to talk about is what's often missed is this idea of site needs. So you as a sponsor are often, and I don't know who I'm talking to with this you, but a sponsor is often concerned about their sites not performing. What they often don't get feedback on for a multitude of reasons is why. And that performance may have to do often with what you as a sponsor aren't doing yourself. And those conversations need to be had. And Brad's doing a great job with his podcast, Note to File, and with even his new website, clinicaltrialconfidential.com, to bring light to some of those conversations. But if you have more questions, feel free to tune into the DarshanTalks podcast. Feel free to reach out to Brad, and I'm sure he'll have more information for you.